Right. Now we will talk about the secondary mechanism of injury in patients with glomerulonephritis. We have already discussed in detail that what are the primary immunological mechanisms which trigger the injury or initiate the injury to glomerulus. Right? Now these immunological mechanisms will start next wave of secondary mechanisms of injury. Let me tell you how. There are multiple mechanisms, right? But I will just take one example that let's suppose this is glomerular basement membrane. Okay, I will make a simpler diagram. We'll make a prototype diagram in which I show that how injury of immune system injury can initiate next wave of injury to glomerular structures. Of course, what are the cells here? And of course, here are mesangial cells. Now, let us suppose that there is antigen and antibody reaction here. Here is antigen and here is, yes please, antibody. Now, formation of immune complex here or deposition of immune complex here is an example of primary mechanism of injury. Now it will trigger the secondary mechanism. Now what are the secondary mechanism? One secondary mechanism may be activation of complement system. That if this antibody is IgG or IgM, its Fc portion is activated, it may bind with complement number 1, C1, and C1 when it is activated, it activates complement number 4, and complement number 4 will activate complement number 2. Is that right? So these antigen antibody complex activate the complement system by classical pathway C142. Now C4b and 2b, because their A components are released, they will activate C complement number 3, C3b, and A will be released, and all of them together, C4b, 2b, C3b, together all of them will activate C5. So C5b will be there, A will be released, and C5b will bind with 6, 7, 8, and 9. Now what is really happening? Concentrate on this. The antigen antibody deposited complexes have a power to activate the complements. In this example, they are activating the complement by the classical pathway, right? And by classical pathway, in the end, they are producing C5b, 6, 7, 8, 9. Whole this is called membrane attack complex. Now, lot of membrane attack complexes are produced. They will attack and digest and damage the endothelial cell. They will damage the, yes, glomerular basement membrane, and these products will damage the epithelial cell. So this is an example of secondary mechanism of injury. Is that right? Then even membrane attack complex may attack if some of this diffuse to mesangium, they will damage the mesangium. So what we can say that initial injury was antigen antibody complex, right? Secondary mechanism is complement activation. One way how complement damages by generating lot of membrane attack complexes. Membrane attack complexes have power to damage the endothelial cell or GBM or epithelial cells or mesangial cells, right? Of course, then it's easy to understand. If there's little damage, you will develop proteinuria only. If there's more damage, you will develop nephrotic. If still more damage, you may develop nephritic. Anyway, now, then C4A, C2A, C3A, C5A are also released. These A components have their own activity, right? For example, C3A and C5A can activate local mast cells. C3A and C5A will activate local mast cells. Local mast cells will, once they are activated by C3 and C5A, they will release, let's suppose some mast cells are here, right? And these mast cells, which are activated by C3A and yes, C5A, they will release their product. By the granules, they will release histamine, and they will release proteolytic enzyme proteases, and they from their membranes they will release prostaglandins, and they will release platelet activating factor from their membranes, and they will release other components from the cell. Now what is happening? Histamine will alter the glomerular blood flow. Proteolytic enzymes which are released will damage mesangial cell or endothelial cell or GBM or the epithelial cell. Prostaglandins then will further alter the hemodynamics of the glomeruli. So another wave of injury will start. Is that right? Then move further. C5A, which is released, that is also chemotactic for neutrophils. So any neutrophils which are passing by, they will be activated by C5A, and those neutrophils become active. And now this neutrophil, it wants to phagocytose this immune complex, right? During this process, when neutrophil is trying to phagocytose immune complexes, because it is activated, right? This neutrophil may release, yes please, what it will release? Oxygen derived radicals, or it may release proteolytic enzymes, lysosomal enzymes, or neutrophil membranes may release also prostaglandins and leukotrienes and platelet activating factors or many other reactive components. And if neutrophils are activated for longer time, they may start producing another wave of cytokines like interleukin 1 or tumor necrotic factor. So do you think it's a good news for the patient or bad? Bad. So initial injury, you have to remember, was just immunological, but that has produced secondary waves of injuries by activating complement mechanisms or cell mediated mechanisms. Here, right, neutrophils are activated. Then when inflammatory reaction is going on, when neutrophils are activated, what will be further? After some time, when acute inflammation continues, macrophage will become activated. And when macrophage will come into that area, what they will do? Right? What macrophage will do? Once they are activated, they will produce their product. Again, oxygen-derived radicals, again, proteolytic enzymes, lot of cytokines, right? And all these things damage the endothelial cell or digest this glomerular basement membrane or epithelial cells. So secondary injury may be mediated by complements and their products, may be mediated by neutrophils and macrophage and their products, or when so many endothelial cells are injured endothelial cells love to stick platelets. I think you must be knowing it. When endothelial cells are injured, what binds to injured endothelial cells? Platelets. So a lot of platelets stick over there. Right? For example, membrane tag complex damages the endothelium. Endothelium can be damaged by the membrane tag complex, it can be damaged by the neutrophil product, it can be damaged by the macrophage product, and when endothelium become injured, platelets start binding there. When a lot of platelets start binding there, they will produce microthrombi and ischemic injury will start. Do you think things are getting better or worse? They're worse. Another wave of secondary injury. So let's sum up. Whatever the initial immune insult, that may trigger different secondary mechanisms of injury. That may be complement mediated injury, that may be neutrophil mediated injury, or macrophage, or platelets, or mast cells, and don't forget a very aggressive friend, mesangial cells. Normally they are not very dangerous cells, but when they are irritated by different product, right, they themselves convert into dangerous cells that they start producing. Like neutrophils and macrophages, mesangial cells start producing oxygen-derived radicals. They start producing proteolytic enzymes. They start producing prostaglandins and leukotrienes and many other soluble substances. And if injury becomes really very, very chronic, then mesangial cell will produce growth factors. What are these cells? Macrophages will also produce growth factors. And some lymphocytes may come into that area, and activated lymphocyte may also produce growth factors. When these growth factors are produced so much, severe injury and prolonged injury, that may lead to proliferation of mesangial cells. And if mesangial cells proliferate too much, right, they will compress the glomerular capillaries and damage the whole glomerular architecture. Then these growth factors also lead to in some cases endothelial cell proliferation. In some very severe cases where injury is so severe that glomerular basement membrane ruptures. The glomerular basement membrane rupture, lot of product come here and they act as a growth factor on the epithelial cells, and epithelial cells multiply and they make even crescents. Are you understanding? But one thing, this is when injury becomes really very severe. But whenever injury is even little, very mild, the first response is these become angry. Who are these? Epithelial cells. When you become angry, your face becomes beautiful or it becomes swollen. Your face becomes like that. This is exactly happened with this cell. Even with little injury, they know how big things are going to happen. So they become very upset, angry and sad cells. Which are these cells? Podocytes. They are very, very sensitive. And any mechanism of injury to glomeruli will disrupt the business of these cells, and these cells will alter. They will swell up. When they will swell up, do you think their food processes will remain so well? No. And what really happens, that this is a healthy, what is this? Healthy epithelial cell, podocyte. When it becomes injured, with little injury, it becomes like this. And with a little more injury, it becomes like this. It is so much swollen that its food processes are effaced. The word which we use is food processes are effaced. Some books write food processes are fused. Actually, they are not fused. They are simply effaced. Is that right? So some books say there's loss of food processes, or disappearance of food processes, or fusion of food processes, but right word is that simply when the cells swell up, food processes disappear. They are effaced. Now remember one thing. These are the food processes which have a special protein at their tip, and this protein is called nephrin, and which keep a very good relationship, normal relationship between these cells and GBM. Even with little injury, when food processes are effaced, these cells cannot keep the normal relationship with the GBM, and whole system become highly permeable and proteins start leaking down. So even with little injury, proteinuria will start. Is that right? Whenever the epithelial cells are effaced. Am I clear? No problem up to this. So next time if someone asks, what are the primary mechanisms of injury and what are the secondary mechanisms of injury in glomerulonephritis? Primary mechanisms of injury are immunological injuries. And secondary mechanisms of injury are maybe complement mechanisms, or they may be the cytokines produced by these cells like interleukins and tumor necrotic factors and growth factors, or they may be neutrophil mediated injury, macrophage mediated injury, platelet mediated injury, lymphocyte mediated injury, right? Complement product mediated injury, right? And then growth factors which are produced, they also mediate injury by activating the pathological growth of the local cells. Am I really clear? And of course, many products which are produced here, they disturb the hemodynamics of the cells. For example, prostaglandins, leukotrienes, histamines, endothelins, they also alter the blood flow through glomeruli. So structure and function of the glomeruli become abnormal. Is that really clear to everyone? Once you have understood this, secondary mechanisms of injury, right? Let's sum it up here and then we'll move to the next step. What are the morphological changes of in the glomeruli? So secondary mechanisms of injury, this is leading to secondary mechanisms of injury. That may be cell-mediated injuries or those may be soluble factors. Soluble factors. Of course, many cells are producing these soluble factors, and cells, I said, they may be, yes, what are these? Neutrophils, or they may be macrophages, or they may be lymphocytes. Remember, neutrophil, you should show multilobated nucleus. Nucleus with multiple lobes. Macrophage, indented nucleus, bean-shaped nucleus. Lymphocyte, very big nucleus and little cytoplasm. Right? And platelet-mediated injury. Right? These are the cells which are immigrant cells. Then resident cell may also do the damage. For example, mesangial cells, they may start producing dangerous product, right? The soluble factors which are produced in that area, of course, oxygen derived radicals. Then there are proteolytic enzymes. Then there are cytokines of many types. For example, there may be tumor necrotic factor. Yes, there may be interleukin 1. There may be transforming growth factors, different type of growth factors. Then, of course, you should not forget your best friend, complement, which complement to injury actually, right? So these are few examples that secondary mechanisms of injury are activated, right? Now, depending upon the severity of the injury mechanisms and duration of the injury mechanisms and type of the injury mechanisms, there will be different morphological changes in glomeruli. Is that right? Now let me tell you what could be the different changes in glomeruli. Let's suppose this is a glomerulus, right? And here is now if there's very mild injury, if there is very okay, before really I go to changes in glomeruli and their morphological changes, I must discuss few terms, basic terms, because now according to the morphological changes in glomeruli, we classify the glomerulonephritis. Before really I start this classification of glomerulonephritis, morphological and histological classification of glomerulonephritis, it's important to know certain terms, right? First I will talk to those terms. For example, there's a term used, okay, let me make few kidneys here. Suppose these are 4 glomeruli in every kidney. They are representative of course, whole 1.2 million nephrons. Right? Now, if all the glomeruli are suffering, if every glomeruli is suffering, the disease is said to be diffuse. We call it diffuse glomerulonephritis. If all the glomeruli are suffering, you take a biopsy and most of them are showing the pathological changes, we say glomerulonephritis is diffuse. Is that right? Then, if only few are showing changes and some of them are healthy, these glomeruli are healthy and others are, so then we say disease is not diffuse, disease is focal. So, according to the percentage of glomeruli involved, if most of the glomeruli are involved in injury process and under the microscopes they show the changes, we say there is diffuse glomerulonephritis. But if only few glomeruli are involved and other glomeruli are not injured, we say disease is focal. Then another term, if a particular glomerulus which is involved, right, if this is involved completely, all the glomerulus is involved completely, we say the disease process is involving the whole glomerulus, so we say it's global process. Global glomerulonephritis. Opposite to that, you may come across some other patient in which when you do the biopsy, you find that a part of glomerulus is injured and rest of it is healthy. So only a segment of glomerulus is injured. So we say glomerulonephritis is segmental. What is the term here? Segmental. Is that really clear? If all glomeruli are sick, this is diffuse disease. If few are sick and few are apparently normal, this is focal disease. And the glomeruli which are sick, they are completely sick in all the areas, this is global. And if they are partially sick, then it is segmental. Now let me tell you. If a patient has all glomeruli involved and every glomerulus is fully involved. Let's suppose I make a diagram here. Now you have to make a comparison in these two kidneys. 1, 2, 3, 4. Now, let's suppose in this case all the glomeruli are involved and they are completely involved. And second case, some glomeruli are involved and they are partially involved. So this disease where all glomeruli are involved and completely involved, we say glomerulonephritis is diffuse global glomerulonephritis. Is that right? And if few glomeruli are involved and only partially, what do we call it? Focal segmental glomerulonephritis. Is that right? Sometimes immune process and secondary mechanism of injury which are damaging the glomeruli, during the damage many cells proliferate, and when you see under the microscope glomerulus, the glomerulus look hypercellular. The experienced histopathologist knows that what should be the degree of cellularity in a healthy glomerulus, right? Sometimes when glomeruli are severely inflamed, lot of neutrophils come in, lot of macrophages come in, lot of lymphocytes come in. So cell number will become less in a glomerulus or more? More. At the top, maybe endothelial cell, mesangial cell and epithelial cell also proliferate. So we say there are added immigrant cell and resident cell has also proliferate. So glomerulus will become hypocellular or hypercellular? Hypercellular. When glomerulus become hypercellular, right, we use the term proliferative glomerulonephritis. The term which is used is, yes, proliferative glomerulonephritis. So next time if I talk to you, patient has diffuse proliferative glomerulonephritis. Do you understand what does it mean? All the glomeruli involved and cells are over proliferating and overly migrating to glomerulus, maybe inflammatory. It must be mild injury or severe injury. This must be severe. Is that right? Any questions about these basic things? There is no. Okay. Having said all of this, now let's go to the more concepts related with morphological changes. Okay, before I go for that, there are different ways to talk about the morphology of glomeruli. Number one, when you talk about morphology of glomeruli, you talk about the cellularity. Cellularity in glomeruli. I'm talking about the because glomerulonephritis is very commonly diagnosed by the what thing? Histopathology and electron microscopy and by immunofluorescence. There are three basic tests which are done very commonly. Light microscopy, yes, electron microscopy and immunofluorescence. These three tests are very commonly done in patients with glomerulonephritis. Light microscopy, when you are doing light microscopy, what you look in the patient glomeruli? You look at the number one. Light microscopy, you look at cellularity. Is that right? Number two, under light microscope, you must look at the glomerular basement membrane. Is it normal or is it thickened or is it splitting at some points, right? Under light microscope. Number three, right? These two things at least you have to talk about. What is the cellularity of glomeruli and what is the features related with glomerular basement membrane. When we do electron microscopy, we look into more detail. Especially, we look at the health of what are these cells? Epithelial cells. Right? Under electron microscope. That are their food processes effaced or not? Is that right? Which is a very early indication of injury. But it is shown by electron microscope in a better way. Am I clear? Then electron microscope should also show you that deposits, because many deposits of antigen antibody deposits or complement deposits, they are electron dense, so they can be seen under electron microscope. Is that right? Then in immunofluorescence, We also do immunofluorescent studies on the glomerular biopsy material. Now, first I have to give you basic concept related with what is your concept of immunofluorescence. Then we'll see what are the findings in injured glomeruli and how it relate to the disease process. What is our really concept of immunofluorescence? Let's suppose there is a very innocent donkey here. Donkey, husband of a female donkey, right? This is a donkey here, right? Now, you have never, why you are laughing? Even the female donkeys have a right to have male donkeys, right? Okay. Now, so this is a donkey living a happy life. Unfortunately, one day Dr. Jose catch it and inject the donkey, let's suppose, with injection of human antibodies. For example, injected with IgG. A donkey has been injected with human IgG. Do you think for donkey, human antibodies are self or non-self? Non-self. So donkey will think these are foreign proteins. So donkey will make antibodies against our injected antibodies. Are you understanding? So injected antibodies will stimulate the immune system of the donkey, and then donkey will make anti-human antibodies. More truly speaking, donkey will make, or animal will make, antibodies which are against our own antibodies. We'll bring these antibodies out in a bottle. I think bottle has to be a little bigger. These are donkey derived antibodies, but these are against our IgG. Then on the tails of these Fc portion of these antibodies, we add fluorescent material. What we add here? Fluorescent material. Am I clear? Now these are the donkey animal derived antibodies, right? And these antibodies are fluorescent. Is that right? Now what you do? You take the patient glomerular biopsy. On the biopsy material, you put these what? Antibodies, fluorescent antibodies. Let's suppose this is a glomerular basement membrane in the biopsy material, right? When you put these antibodies there, if there is, during the immune damage, if there was any IgG, let's suppose there was anti-GBM IgG there. What is this? Anti-GBM IgG against the collagen type 4, non-collagenous component of the type 4 collagen. There was already in the patient body antibodies. So antibodies will be deposited in a linear fashion, but can you see the antibodies by electron microscope? Answer is no. So what you do, you take the biopsy and put this anti-IgG. Now what happens? These antibodies will react with the deposited antibodies. Are you understanding? And now you wash. Do you think these antibodies will wash away? No, because they're sticking with the target antibodies. And then you see it with polarized light or ultraviolet light, and you will find there is a linear pattern of fluorescence there. So immune system, immunofluorescent molecules were your antibody which were fluorescent, right? So when you see there's a fluorescent pattern there, and this antibody was directed against IgG, it means patient glomerular material has what? IgG. In the same way, doctors have made antibodies against IgG, antibodies from the animals against IgM, and doctors have made antibodies against complement factors. For example, catch another donkey and inject the donkey with complement number 3. So donkey will provide you with anti-complement 3 antibodies and fluorescein it. So when you take the glomerular biopsy, on the biopsy material you put the fluorescent antibodies. If these fluorescent antibodies are anti-C3, you put the antibodies and wash, and everything is washed and nothing there. It means this glomerular disease does not have C3, complement C3 deposited there. But if they remain sticking, it means complement C3 is there. Now you understand it. So in this way, immunofluorescence help you to find the immune components deposited within the injured glomerulus. This is the purpose of doing immunofluorescence, because when you study glomerulonephritis, you study like that there are immunofluorescent studies. Now listen. Immunofluorescence can help in two ways. Number one, it can tell you what type of chemical substance is there. It can tell you there's IgG deposited or IgM deposited or IgA deposited or C3 deposited or not deposited. This is one advantage of immunofluorescence, right? Another advantage is that immunofluorescence in a immunofluorescent pattern in different glomerulonephritis may be somewhat different. For example, when you have anti-GBM, anti-glomerular basement membrane diseases, then there will be linear immunofluorescence. But if you have, let's suppose, another disease, someone has some antigens deposited here, some immune complexes deposited here, some immune complexes deposited here. When you do fluorescence, do you think this fluorescence will be linear or it will be granular? Granular. So what really happens, that fluorescence along the glomerular basement membrane, you see it's linear or granular. Cause of linear may be different and cause of granular may be different. In the same way, sometimes immune complexes are deposited in the mesangium. And mesangium is not having a line like glomerular basement membrane. If immune complexes are deposited or complement are deposited into mesangium, when you do immunofluorescence, and immunofluorescent antibodies react with the targets in mesangium, they don't make linear pattern. They don't make granular pattern. They make cloudy or fluffy pattern. So it means there are three types of immunofluorescent pattern, right? There can be, yes, there can be linear pattern, and there can be granular pattern, and there can be fluffy. Again, if there's linear pattern along immunofluorescent along the glomerular basement membrane, probably anti-GBM antibodies are there. If they're granular pattern, it means some lumps of immune complexes are deposited. Is that right? And if fluffy pattern, then lumps are not along the GBM, lumps are maybe in the mesangium. Is that right? So these are two advantages of immunofluorescence. That immunofluorescence can tell you, number one, what kind of immunoreactive material is there. Number two, what is the pattern of immunofluorescence? What is the site of deposition of immune complexes and immune component? Am I really clear? Okay, this was our basic discussion to start the typing of glomerulonephritis. Again, if I say there's diffuse glomerulonephritis, it means few glomeruli are involved or all glomeruli are involved? All. If I say there's global glomerulonephritis, part of a glomerulus involved or full glomerulus involved? Full. And if I say there's segmental problem, then a glomerulus is involved partially. And if I say focal disease is there, few glomeruli are involved. If I say proliferative disease is there, it means cells are proliferating too much. And if membrane look thick, we say this membranous disease. Is that right? Any problem up to this? Now let's go to the types of glomerulonephritis. Now, depending upon different factors, there will be different morphological lesions in glomeruli. It depends on what? Number one, it depends on type of injury. Number two, it depends on severity of injury. Number three, it depends on what type of pattern will come. What is the type of injury? What is the severity of injury? What is the duration of injury? And what is the what are the host factor? Because same injury in different patient may produce different type of results. Host factor means your own predisposition for a particular disease. Depending upon these factors, what is the type of immunological injury and what is the severity of injury, what is the duration of injury, and what are the host factors, all these factors will interplay to produce different morphological patterns of glomerulonephritis. Let's start with it. First of all, I will start with, look here. In this case, under the microscope, GBM looks normal. Glomerular basement membrane is normal. No cellularity is normal. Let's suppose there's a patient which have taken the sample of the glomerulus biopsy. So cellularity is normal, GBM is normal, no immunofluorescent finding, no deposited immunoglobulins, no deposited complements. Immunofluorescence never give positive result, right? But under electron microscope, you just find that these cells have, what is this? Effacement of foot processes of podocytes. That's the only change. Is that right? This type of this type of glomerulopathy is called minimal change glomerulopathy. People avoid to call it glomerulonephritis because nephritis means inflammation, but there is no inflammatory cells there. Are you understanding? So this type which I have discussed right now, that is minimal change glomerulopathy. Is that right? In these patients, what you really see is that glomeruli looks normal under light microscope, but proximal convoluted tubular cells show they have accumulated lot of fat. They have accumulated lot of fat. So in old doctors, previously the doctors used to call this disease lipoid nephrosis. Lipoid, lipoid nephrosis. They thought the disease is some lipid accumulation here. But now we know this lipid accumulation has nothing to do with the mechanism of injury. Now we know in this disease primarily some T cells are activated in the body. They produce some cytokines. Those cytokines neutralize the charges here, right, and react with these cells, and these cells lose their normal relationship with the GBM. Due to that, there is very heavy proteinuria, and proximal convoluted tubules reabsorb the proteins and lipoproteins. And a lot of proteins are catabolized by proximal convoluted tubules, but lipids are accumulated there. So this was a result of injury, but not the cause of injury. This lipid deposition here. So some books may be writing minimal change glomerulopathy as lipid nephrosis. Why we call it lipid nephrosis? Because there is excessive lipids accumulated in proximal convoluted tubule, but this lipid accumulation is the result of the injury, not the cause of the injury. Am I really clear? Right? Now, let's start putting the things here also. Clinical presentation may be asymptomatic proteinuria, is that right? Asymptomatic proteinuria, or patient may have non-selective, okay, you can say selective proteinuria, then non-selective proteinuria, okay, you want to start like this, selective proteinuria, then non-selective proteinuria, then patient may have nephrotic syndrome, then patient may have, yes please, nephritic syndrome, then some patient may have acute renal failure, and some patient unfortunately may have chronic renal failure. And of course, somewhere in between we must mention that hematuria, asymptomatic hematuria. Okay, I put it here, asymptomatic hematuria with little protein. Now these are the clinical presentation. These are the morphological presentation. We are now filling up this gap in our concepts. Minimal change glomerulonephritis. It's a very little injury. Do you think it can produce CRF directly? It can produce acute renal failure? Can it produce even nephrotic? No. So this will be clinically coming at very early stage. First it will produce selective proteinuria because only albumin will leak down. Or it may come with nephrotic syndrome. Actually, minimal change glomerulonephritis is the most common cause of nephrotic syndrome in children. Minimal change glomerulopathy is, or minimal change disease is, the most common cause of, yes, nephrotic syndrome in children. Am I really clear? If you have 100 children with nephrotic syndrome, most of them will be proved to have minimal change disease. And that is a good news. God has been merciful to the kids. You know why? Minimal change glomerulonephritis dramatically respond to steroids. So if you really want to have some type of glomerulonephritis, you can pray for yourself minimal change, because it responds well to short courses of steroid, and usually once it is treated, it does not come back. Is that clear? So God has been too merciful to the kids that most of the kids who develop nephrotic syndrome, underlying diseases, type of glomerulopathy is minimal change. Am I really clear? Now, let's suppose we go to another patient. In this patient, glomerular basement membrane is totally normal. Glomerular basement membrane is totally normal, but like minimal change disease, there is loss of foot processes. You are understanding? This is the second patient, another patient. You do biopsy, you find epithelial podocytes have lost their foot processes. Basement membrane is nearly normal. But what you really find, in one glomerulus, there are multiple loops of capillaries. You may find some of the capillary loops. This is one capillary loop, this is another capillary loop. You may find some of the capillary loops are sclerosed, hyalinized. Hyalinization means that under the microscope you find there is pink color, eosinophilic homogeneous material deposited. So what did you do? You did the biopsy and you find, sorry, in the biopsy of this patient you find some glomeruli look healthy, some glomeruli are diseased. So disease is focal. Disease is focal. And glomeruli which look unhealthy, some of their capillary loops are hyalinized and sclerosed, and some of the capillary loops are normal. So this disease should be called focal segmental glomerulonephritis. So this is the second process. What is it? Yes, please. First was minimal change disease. Second is focal segmental glomerulonephritis. Now please, can you differentiate them? Can you really differentiate minimal change disease as having minimal changes in the glomeruli? And focal segmental glomerulonephritis is very different. That focal segmental glomerulonephritis, when you see it under the microscope, you find some of the glomeruli are involved, especially which are near the medulla. The glomeruli which are more near the medulla, they are called juxtamedullary glomeruli. So juxtamedullary glomeruli are having pathological changes, but many glomeruli are healthy. So disease is focal. And glomeruli which are unhealthy, only few loops of capillaries are blocked with hyalinized material. Other loops of capillaries are normal. So they call it focal segmental glomerulonephritis. Again, it cannot be very severe disease because it does not involve all glomeruli, and even the glomeruli which are involved, they are partially involved, not completely involved. So this patient should come with selective proteinuria, or it may come with non-selective proteinuria, or it may come with nephrotic syndrome, or this patient may come to you as nephrotic syndrome. Am I clear to everyone? Right? Now, it means, look at the beauty. If you treat it well, listen carefully. If you treat this patient well, from nephrotic syndrome, he will go to non-selective proteinuria, selective proteinuria, and okay. But if you don't treat well, and underlying immune mechanism is working hard, then from nephrotic, it may convert into nephritis. You are understanding how the interplay is going on? And on the back, you can imagine how immune system is damaging. And severity of damage determines that patient will have upper syndromes or lower syndromes. Am I right? Now we come to another patient. Now, again, minimal change disease and focal segmental disease. Both of them had glomerular basement membrane with normal thickness. The common in these two things was that both of them, patient have normal glomerular basement membrane thickness, and both of them have podocyte with loss of foot processes. The only difference is here there are hyalinizations of or sclerosis of some capillaries. And another difference is this process is involving every glomerulus. This is involving few glomerulus partially. Am I right? Now we go to another patient. An adult come to you with nephrotic syndrome. You do biopsy. And you find that in his biopsy, you find cellularity of glomeruli is normal. But all the glomerular basement membrane are 5 to 10 times thick. There's a new patient, this third patient with us, and on glomerular biopsy, renal biopsy, we find that his glomerular basement membrane is very, very thick. But cellularity is normal. You don't find a lot of neutrophils, you don't find a lot of lymphocytes, you don't find a lot of platelets sticking there, you don't find proliferating mesangial cells or epithelial cells or proliferating endothelial cells, nothing. And on immunofluorescence, you may find, okay, on electron, this is very thick glomerular basement membrane, right? But on electron microscope, you find that on this side, there are some deposits. What are these? Some deposits which have electron density different than the normal glomerular basement membrane. Let's suppose this is normal glomerular basement membrane. Now, this is thickened area. Now what you really see, the green tissue is normal glomerular basement membrane. And these are some immune complexes, the black one. Right? What really happened in this patient, that these are his what? Podocytes, which are of course swollen. What happened? There were some deposits in this area. There were some deposits like this. These are subepithelial deposits or subendothelial deposits? Subepithelial. They are under the epithelium. Subendothelial should be here, under the endothelium. This is endothelial cell, my friend. And subendothelial should be here. But it is subepithelial. Is that right? Now, subepithelial deposits were there. They irritated these cells. And these cells reactively start synthesizing and releasing more glomerular basement membrane material. So glomerular basement membrane becomes thin or thick. And new material is pushed in between this deposit. So actually, in the books you will write, I hope one day you will write also, but presently you will read in the book, if you do, that there is spike and dome pattern. These are the spikes of GBM moving in between the domes of deposits. Is that right? Spike and dome pattern. Anyway, even sometimes so much GBM is produced new that these cells become more down and whole new GBM is produced and these deposits become intramembranous. They are embedded within the membrane due to deposition of a lot of new GBM material. Are you really understanding or just agreeing with me? You understand it. Okay, that's good. Now, this type of disease, thank God, doctors put a very simple name. They did not put these glomerulonephritis on their personal names. They just found the membranes are very thick. What to call it? They say, okay, call it membranous glomerulonephritis. So name of this condition is, yes please, membranous glomerulonephritis. Right? Again, it is a moderate disease, mild and moderate. So most of these patients come with non-selective proteinuria or they come with nephrotic syndrome. Very rarely, some patient may go to nephritic if disease become advanced. Again, when you think about membranous glomerulonephritis, you have to think about secondary mechanisms. On immunofluorescence, you will find complement 3 deposited there. And here, you may find IgG deposited there. So these are the depositions of IgG, some antigens, and complement 3. So immunofluorescence here will be granular or linear? Granular. I think you really started learning well. Right, so in membranous disease, you will find granular immunofluorescent pattern, and immunofluorescence may prove that there is IgG and C3 deposits. And then you will take the history. Maybe these antigens here, maybe from malaria, or maybe from virus, or maybe from drug. Are you understanding how things are moving? Is that right? Now, membranous glomerulonephritis. Then, glomerulonephritis can be due to some systemic diseases also. Okay, before really I move further, The whole glomerulonephritis are classified in two basic groups: primary glomerulonephritis and secondary glomerulonephritis. What is the difference in primary glomerulonephritis and secondary glomerulonephritis? Anyone? If we have 100 patients with glomerulonephritis, some of them are called primary glomerulonephritis, other are secondary. Listen, those patients who have glomerulonephritis and in their disease process, only the kidneys are the dominant organ suffering. They are called primary glomerulonephritis. But sometimes some people develop glomerulonephritis as a part of some other disease in which many other suffering. For example, diabetes mellitus. It damages the heart, it damages retina, it damages many organs in the body, including the kidney. So if a diabetic patient develops nephropathy, that will not be primary nephropathy, that will be secondary. If someone develops amyloid deposit in multiple tissues and also in the kidney, that will be second glomerulopathy. In patients with systemic lupus erythematosus, they may develop injury to many tissues, including kidney. So their kidney disease or glomerulonephritis should be considered secondary glomerulonephritis. Am I right? But minimal change should be considered primary glomerulonephritis. Membranous may be considered primary or may be secondary. For example, some patient with SLE develop membranous changes. So then membranous glomerulonephritis is secondary. And some people develop membranous glomerulonephritis simply due to some antigen which get planted and attack and no other problem in any other part of the body. Then membranous glomerulonephritis will be primary. Is that right? Am I really clear? You are yet not confused? You refuse to be confused. Okay, I like your spirit. Now, so all the glomerulopathies can be divided into primary and secondary. If in the whole disease process, if kidneys are the major organs which are suffering, this is primary. And if kidneys are one of the organs which are suffering, then it is secondary. Now, some people develop diabetic nephropathy. What is that? Diabetic nephropathy. What really happens in diabetic nephropathy, that in diabetic patient, glomerular basement membrane becomes very thick. Now look, glomerular basement membrane was thick in membranous as well as in diabetic. But there's a difference. In membranous glomerulonephritis, only GBMs are thick, but mesangium is normal. Mesangial tissue is normal. But in diabetes, how you differentiate these two glomeruli? The diabetic glomerulus has, of course, lot of GBM thickening, plus it has deposits in mesangium. GBM-like material is also present in mesangium. Is that right? Now you really understand it? So if I show you a glomerulus in which membrane is very thick and mesangium is normal, it should be considered simply membranous glomerulonephritis. But if I show you a glomerulus in which glomerular basement membranes are very thick, plus there are mesangial deposits also, diabetic, especially sometimes in the mesangium, okay, not only glomerular basement membrane become very, very thick, in the mesangium also, you find either there's diffuse enlargement of these are mesangial cells, there's diffuse enlargement of mesangium, or sometimes there's a very, very nodular depositions. These nodular depositions, if they are there in mesangium, they are diagnostic for diabetic nephropathy. If under the microscope you find big nodular deposits of glomerular basement membrane like material in mesangium, they are diagnostic for diabetic injury for many, many years. Right? These lesions are called Camel-Steele-Wilson lesion. Camel-Steele-Wilson lesion. Is that right? Anyway, I'm not teaching you these glomerulonephritis into detail. That will be done in future lecture. But right now I'm just telling you how to develop a concept. So now you have to tell me. If you do you do the biopsy, right? GBM is normal. No sclerosis is there. Foot processes are effaced and no deposit there. What do you think? Minimal change disease. And if another biopsy comes, you find membrane is very thick and no other pathology is seen. But immunofluorescence shows granular pattern of IgG and C3. Food processes are effaced. What is that? Membranous glomerulonephritis. If I show that glomerular basement membrane is normal, epithelial cells are showing effacement, and few capillary loops have sclerosis, others don't have. What is that? Focal segmental glomerulonephritis. On another biopsy, you find that glomerular basement membranes are very thick with few extra deposits of GBM-like material in mesenterium. What is there? That's great. Now we come to another thing. You have to remember, here GBM was normal. Here GBM was normal, but few loops were sclerosed and few loops were normal. Here GBM was very, very thick. Here GBM was very thick and with some mesangial deposits. Can you really differentiate them? There's no problem. Now, diabetic nephropathy also comes as initially selective proteinuria, that is albuminuria. Then it will convert into non-selective proteinuria, and then diabetic nephropathy may convert into nephrotic syndrome. What you are learning? That anyone who comes with just nephrotic syndrome, don't feel great if you make a diagnosis of nephrotic syndrome. You have to see what is the cause of nephrotic syndrome. What is the mechanism behind? Is that right? Now, in the same way, let's go to one more example. Another patient comes and you have thick glomerular basement membrane, and deposits are what are these? Subendothelial. Here the deposits were subepithelial. Here deposits are subendothelial. And I give you a few more features. And in his disease, patient has thrombocytopenia, neutropenia, skin rashes. Very good. SLE. This is glomerulonephritis due to SLE. Because in SLE, systemic lupus erythematosus, there are a lot of circulating immune complexes. These very big immune complexes get stuck into glomerular structure. But because these are large glomerular complexes, they don't go really to subepithelial area. Most of them are stuck into subendothelial area, right? And sometimes membrane look thick, and they say this is also membranous glomerulonephritis due to SLE, right? But because other features of SLE are also there, so this membranous glomerulopathy is primary or secondary? You are becoming a nephrologist. I'm impressed. Yeah, I'm impressed. Now, in SLE, patient may come with selective or may come with non-selective proteinuria or with nephrotic syndrome, or if SLE becomes really very advanced, patient may convert into nephrotic syndrome. Is that really clear? No problem up to this. Now, another case in which, have you heard of amyloidosis? What is amyloid? Amyloid is amyloid. What is amyloid? Abnormal protein. Do you think every protein which is abnormal is amyloid? Oh my God. Someone has to tell me what is amyloid. Then lecture will continue ahead. Look. First we start with a very basic concept. All the proteins which are within the cell, listen, most of the proteins which are within the cell or outside the cell, their peptide chains are arranged like this. This is called alpha helical arrangement. So most of the proteins are dominant which structure? Alpha helical. And rather all of our proteolytic enzymes can cut only alpha helical arrangement. Is that right? We have a lot of proteolytic enzymes. These can cut only alpha helical arrangement. Sometimes what happens, a protein does not go into spring shape arrangement. Rather, protein in our body become like this. This is called beta pleated arrangement. And we do not have any enzyme in our body to cut the beta plating. So once this protein is formed in our body, it's going to stay there forever. There's no way to get it out. Is that right? So sometimes there is an abnormal protein produced from our body which is beta plated, and these beta plated proteins which are outside the cells, they are called amyloid. What are they called? Amyloid. Now listen, even transthyretin, a protein which transfers the thyroid hormone, that become beta plated, that is called amyloid. If light chains of the antibodies kappa and lambda, if they become beta plated, they are also called amyloid. Some other proteins which are produced by liver, if they become beta plated, they are also called amyloid. What does it mean? That amyloid, if you bring amyloid from 100 different patients, right, all of them will have same physical characteristics, but they may have different chemical composition. So any protein, for example, Mr. Carlos is so wise, I hand over him insulin. He open up the alpha helical and make the beta plating. Now this insulin will be called amyloid. Do you understand it? So what are amyloid proteins? Amyloid proteins are abnormal proteins which are extracellularly present in our body due to some disease process in which proteins fold abnormally. They are beta plated folded which cannot be digested away. Once they are there, they are there. The classical example of that is silk. You know silk? Suture, silk suture. Do you think they absorb or not? When you put the sutures, there's a special type of suture, we call them silk suture. Silk is a protein which is beta plated. So if you make the silk thread suture, that will stay forever there because you don't have enzyme to eat up those sutures material. But there's cat gut. You know cat gut? That is alpha helical arrangement. So when you put suture with cat gut, initially it holds the tissue together, but later on macrophage will digest that away. Do you understand it? So non-absorbable suture like silk sutures are what? Not amyloid because they are not our protein. Amyloid are human proteins produced in human body undergoing beta plating and going to stay there for a long time. And amyloid have very special what? Staining characteristics. They stain with Congo red. Special stain Congo red is taken by these beta plated, and under the special light, polarized light, under the polarized light, amyloid proteins show green birefringence. You understand what is the meaning of birefringence? Don't. Okay, let me tell you. Actually, amyloid proteins are long fibrils of proteins. Long fibrils of protein, non-branching. Let's suppose these are some fibrils like this. There's another fibrils like this. Now, let's suppose Congo red only stick to this area but does not stick to the side. So it means only these areas are having better stain and area which is like this is having less stain. Let's suppose this is my hand. Now what are these? Amyloid fibrils. Now special color is taken more by my fingertips, but the color is taken poorly inside. Is that right? Am I clear? Now if the color is Congo red and you show polarized light, when you will rotate the light, right, then sometimes you are seeing the tips, sometimes you are seeing the sides. So from the tips you will see different color, from the sides you will see different colors. And when you look at it, it is quite possible if there's a lot of amyloid fibrils, some are lying like this, others are lying like this. So here you are looking at tips and here you are looking at the sides. So this will give different color and this will give different color due to differential uptake of staining. This is called birefringence. That is double refractory mechanism. Light which is reflecting from here has a different color and from here it is different. So this is a very, very special characteristics of amyloid protein. Anyway, this lecture is not on amyloid. Let's come back. I just wanted to say that in some conditions, a lot of amyloid proteins are deposited in kidney. And when amyloid material deposit into kidney, that disrupts the glomerular structure. Amyloid are specially deposited in mesangial tissue and on GBM. Where they are deposited? Glomerular basement membrane. So glomerular basement membrane become thick. In renal amyloidosis, glomerular basement membrane become thick, but this thickness is due to amyloid material. Plus amyloids are also deposited in where? Mesangium. So this type is renal amyloidosis. These patients also can come with selective proteinuria, non-selective proteinuria, nephrotic syndrome. Usually they don't go to nephrotic until they become very advanced. Is that right? So it means the patient who comes with nephrotic syndrome, he may have any of these 6 conditions. Is that right? But usually the most common cause of nephrotic syndrome in children is minimal change disease. Most common cause in young adult. Most common cause of, I will repeat it. Most common cause of nephrotic syndrome in children is minimal change disease. Most common cause of nephrotic syndrome in young adult is membranous glomerulonephritis. Most common cause of adult nephrotic syndrome, adult from African descent is focal segmental. Are you understanding it? Now, of course, if a patient has already diagnosed case of diabetes from last 20 years, and now he develops nephrotic syndrome, most probably he is developing diabetic nephropathy. Or someone who has already SLE and developing now nephrotic syndrome, probably it is SLE related glomerulonephritis. Is that right? In the same way, if someone has some disease in which amyloid is produced, can you tell me any disease in which amyloid is produced in the body? Diseases in which there is chronic inflammation like rheumatoid arthritis, like tuberculosis. In chronic inflammatory diseases, chronic inflammatory cell force the liver to produce special proteins, and in some patients, those special proteins convert into amyloid. Do you want to know the name of those special proteins? SAA, serum amyloid associated proteins. Again, listen. If I'm having a chronic inflammatory disease, chronic, maybe rheumatoid arthritis, maybe tuberculosis, maybe any chronic, it means chronic inflammatory cells are active in my body. Chronic inflammatory cells will produce interleukins chronically. If liver is too much stimulated by chronic inflammatory cell product, liver cells start producing SAA. And SAA, serum amyloid associated proteins, in some patients, not all patients, may convert into amyloid. Right? In the same way, there is another disease called multiple myeloma. You know multiple myeloma? What is multiple myeloma? Okay, she knows the name of multiple myeloma. What is multiple myeloma? Multiple myeloma are the malignancies of plasma cells. You know plasma cells are active B cells. You know B lymphocyte, when they become active, they convert into what? Plasma cells. And if a plasma cell becomes malignant, disease is called multiple myeloma. And when plasma cell become malignant, sometimes they produce abnormal kappa and lambda chains. And those abnormal kappa and lambda chains may undergo amyloid formation. So many patients with chronic diseases have amyloidosis. Many patients with multiple myeloma may have amyloidosis. And amyloidosis may involve kidneys. And then membranes will become thick. But under electron microscope, membranes will show additional deposits with crisscross arrangement of fibrils. Amyloid fibrils can be seen under electron microscopes like crisscross, like this. And they are stained especially with, yes please, Congo red. And these deposits are also seen in mesangium. Am I clear? No problem up to this. So these 6 types classically produce up to this nephrotic. Right? Now we go to some more severe problem. Let us suppose there is another patient who develops severe streptococcal infection in the throat or in the skin. Lot of streptococcal antigens and anti-streptococcal antibodies, they make immune complexes. Or lot of streptococcal antigens from the blood go and deposit into his kidney. And later on antibodies also go. So there's very severe antigen antibody activation in the glomeruli. I'm talking about what? Post-streptococcal glomerulonephritis. I'm talking about post-streptococcal glomerulonephritis. That after streptococcal infections, streptococcal antigens get planted into kidney and then antibodies follow. Then complements are activated. Then neutrophil, macrophage, oh my god, severe reaction. And epithelial cells are damaged, endothelial cells are damaged by complement, platelets stick. You're understanding? So this highly inflamed glomeruli. And in reaction to that severe inflammation, glomeruli become overloaded with neutrophils and macrophages, and even some local cell also proliferate. So that should be proliferative glomerulonephritis. And because that involves all glomeruli, that should be diffuse proliferative glomerulonephritis. Is that right? Because that occurs after infection, we call it what we call it? Post-infective diffuse proliferative glomerulonephritis. It's very severe, right? So this will classically come as, yes, nephritic syndrome straight away. But usually most of the patients are lucky that antigenemia disappear. Antigen antibody complex is eaten up by macrophage, and within few weeks patient become okay. So it produces nephritic syndrome, but this nephritic syndrome resolves. Am I really clear? So this is called post-streptococcal diffuse proliferative glomerulonephritis or post-infective, because some other infections can also produce such type of glomerulonephritis. So better word is post-infective diffuse proliferative glomerulonephritis, clinically coming as nephritic syndrome. If you move backward, what you will find? Secondary mechanisms, lot of complement deposits, lot of neutrophil, lot of macrophages, lot of platelets stuck there. If you move further back, you will find that there are a lot of lumpy, bumpy deposits of antigens and antibodies on the glomerular basement membrane. Are you understanding how we moved from antigen, antibody, lumpy, bumpy deposits, secondary mechanisms of injury, cells develop diffuse proliferative glomerulonephritis, clinically coming as nephritic syndrome. You are understanding? Okay. I'm impressed you can understand for such a long time. Yeah, because people get really tired, sick of me within 20-30 minutes when I teach this topic. But you people are still listening. Yeah, that's good. It's appreciable. Now, post-streptococcal diffuse glomerulonephritis. We come to another disease. Another disease is, look here. This is glomerular basement membrane. Attention please. This is glomerular basement membrane and antibodies are formed against GBM. What is this? Anti-GBM antibodies. Attacking against what thing? Type 4 collagen. Which component? Non-collagenous component of type 4 collagen attacked by the autoantibodies. Which type of hypersensitivity reaction? Antigen is intrinsic and fixed. Type 2. Type 2. Is that right? Anti-GBM antibodies are very, very aggressive. And another bad news. Similar antigens are also present in alveolar basement membrane. So patient develop renal attack with pulmonary attack. Immune system attack at both tissues. That is, glomerular basement membrane is being attacked by the antibodies as well as alveolar basement membrane. When basement membrane is ruptured at many places, patient may develop hematuria here and hemoptysis there. So very commonly question is asked, a young male comes and he has hematuria with hemoptysis. What is the most probable cause of? They have given the choices, right? And the choice is probably anti-GBM antibody as anti-alveolar basement, ABM antibodies are there. Is that right? Do you think there's anything good about this disease? There's nothing good about this disease. It's very aggressive. Sometimes it becomes acute renal failure or sometimes chronic renal failure. There's nothing good about this disease. But I don't know why they call it Goods-Pasteur syndrome. They have put a name, Goods-Pasteur syndrome. There's nothing good about this disease. Is that right? Are you understanding what is Goods-Pasteur syndrome? In which autoantibodies reacting against the basement membrane and the glomeruli as well as alveoli. So patient should develop hematuria with hemoptysis. Plus, now look at his renal syndrome. Patient may develop initially hematuria. If patient disease advances, he will go for nephritic syndrome. He will go to nephritic syndrome. And if disease further advances rapidly, he may go into acute renal failure. I will explain. How? In many of the glomerulonephritis, injury is so severe. In many of the glomerulonephritis, I will make a diagram here. Actually, this diagram should be here, right? This has been transferred here. Let's suppose this is glomerular basement membrane. And here is what? Your beautiful, what is this? Bowman capsule. And here is your, in anti-GBM diseases or in some other immune mediated injuries, there is so severe injury here that GBM ruptures at many places. What is the special lesion? Not the simple thickening. It becomes ruptured, wrinkled and ruptured GBM. And when GBM is so much wrinkled and ruptured, oh my God, lot of fibrin come from here. Fibrin deposits here. From inflammatory process, lot of cytokines come here. Even lot of macrophage come here. All of them produce so much stimulation that parietal cells start proliferating. These, what are these parietal cells? These start proliferating. So what was the influence for proliferation? Fibrin and its breakdown product, macrophage and their product, and severe injury and platelets and platelet-derived growth factors. And when you see under the microscope, glomerulus look as if it has a crescent, but this is a crescent of death. Some people call this type of glomerulonephritis simply, yeah, they call it crescent glomerulo. Yeah, she knows it. Crescent glomerulonephritis. Good. This is crescent glomerulonephritis. So what is crescent glomerulonephritis? Any type of very severe damage to glomeruli which can lead to simple disruption, rather ruptures of glomerular GBM may end up into what? Crescent formation. Now listen carefully. Even sometimes focal segmental may convert into crescents. Even sometimes focal segmental may go into crescent. Sometimes in SLE patient at very advanced stage, they may convert into crescent glomerulonephritis. Sometimes anti-GBM, Goods-Pasteur syndrome may develop crescents. Is that right? So crescent glomerulonephritis may be due to multiple causes. It is just a morphological expression of glomerulus that it has been insulted very ruthlessly. Is that right? When so many crescents are formed in the glomeruli, do you think urine GFR will form? Filtration will occur? No. So kidney will rapidly fail over the weeks and months. And we say disease is rapidly progressive to failure. Disease is rapidly progressive to failure. That is why another name for crescent glomerulonephritis is rapidly progressive glomerulonephritis. They are one and the same thing. Rapidly progressive glomerulonephritis or crescent glomerulopathy, one and the, yes please, same thing. And this patient will initially come with nephritic but very rapidly convert into acute renal failure. Such patients who develop crescent nephropathy or glomerulonephritis, they just come with nephritic syndrome and very rapidly they convert into, yes, what? Acute renal failure. Is that right? Any question up to this? No? We are going to more dangerous things and we are at the end now. Don't be upset. Now you will tell me. Another patient comes, you do the biopsy and you find two things. Number one, glomerular basement membranes are very thick. Plus, endothelial cells and mesangial cells are too much proliferated. But crescents are not there yet. What is this? Membranoproliferative glomerulonephritis. Now listen, post-infective was also proliferative. But in that case, membrane was not thickened. Now we are coming across another patient in which membrane is very thick. And what is there? Membrane is very thick and cells are proliferated but not making crescents. So this is called proliferative glomerulonephritis. So here is membranoproliferative glomerulonephritis. A very special thing is that under the electron microscope, GBM shows, what is this? Does it remind you something? Tram track appearance. Track of a tram. Membrano, what? Proliferative disease. Under electron microscope, the GBM looks as if it is duplicated and there are some deposits in between. So we call it tram track appearance. So what is there? Very thick GBM with lot of proliferated cells, but not crescents. So then we call it membranoproliferative glomerulonephritis. Look here. Membranoproliferative glomerulonephritis, really concentrate here now. This may come as initially non-selective proteinuria, very early stage, then it convert into nephrotic, then it convert into nephritic, and if you don't treat it, it may convert into ARF. Because if it becomes very aggressive, if you are not treating, this will start forming crescents. It will start forming crescents because membranes start rupturing, and then it will convert into crescent glomerulonephritis. Now you see how underlying mechanisms change the pathology and how altered histopathology changes the syndrome. Am I right? I think some of you are about to die. Okay, who is sleeping? Raise your hand. The person who is sleeping should raise his hand. Okay. Sleeping people don't hear me. That is why no hand is raised. Now listen, what I'm talking about, let's review with your help up to now what we have done. Okay, before really review, the most important, most common glomerular disease I have not discussed yet. Look, in some children, when they develop respiratory tract infection or some viral infection, their immune system become active. Of course, in every children, immune system should become active when they have viral infection. And if this is gastrointestinal infection or it is respiratory tract infection, then antibodies which are made against the viruses should be IgA group. You know, immunoglobulin IgA classes the antibodies on the mucosal membranes. Do you know that or not? There's something like that in immunology, that the antibodies which are specially secreted on the mucosal surfaces is IgA. Some children, when they develop the infections, they make IgA. And some of this IgA goes into blood and then get deposited into mesenterium. In some children, IgA aggregates get deposited in mesenterium. And when IgA deposits, okay, I'll make this place here. IgA deposits are in the mesenterium. We call it IgA nephropathy. What we call it? IgA nephropathy. In IgA nephropathy, mesenterium develop inflammatory lesions because when IgA will deposit, that will activate alternate complements. Right? This is called IgA nephropathy. Or it is given another name, Berger disease, B-E-R-G-E-R, Berger's disease. Globally, this is the most common cause of glomerulonephritis. What is the most common cause of glomerulonephritis worldwide? Berger disease, B-E-R-G-E-R. Or it is called, she wants to call it Berger disease. Still it's okay, no problem. It is Berger disease or Berger disease. You have, it is Berger disease or Berger disease, I don't mind it. As far as you remember, this is IgA. Is that right? IgA deposits there. But once they are deposited, baby develop just a very benign type of hematuria just for 2-3 days. And then baby become okay. Because IgA deposits are taken up by macrophages and eliminated. Is that right? So one of the commonest, rather the commonest glomerulonephritis all over the world is what? IgA nephropathy. Usually it presents as Berger disease or Berger disease. Is that right? Now, the thing which you have to remember is that it is usually innocent. It does not convert usually into nephrotic or nephritic. It just comes as asymptomatic hematuria. And usually it resolves on his own. Is that right? Then now the last condition which I will discuss. I should see. Is there any second last? Last condition is hereditary disorder. We call it Alport syndrome. In this case, the alpha chains in type 4 collagen are mutant. And type 4 collagen is mutant and GBM is not strong enough. And in patient with Alport syndrome, because GBM is weak, so they develop defects in glomerular basement membrane, and due to that reason, these people develop what? Hematuria, or even they develop nephrotic syndrome, and by the age of 30 year, they develop chronic renal failure. Is that right? These people with this inherited disorder. Alport syndrome has also additional problem with the hearing. They have hearing defects because in the inner ear there is basilar membrane for the hearing purpose. There are inner ear and they are having basilar membranes, right? Those basilar membrane, basement membrane is also not okay. Plus these patients also develop ocular problem, cataracts in the lens, and lens may not be suspended at normal position because the ligaments which hold the lens into position, they may have mutant proteins. What is the name of those ligaments which hold the lens into position? Suspensory ligaments, right? That's good. So after that, having said all of this, now let me take you the last thing here. Any one of this become chronic. Any one of this become chronic. Eventually convert into what? Chronic glomerulonephritis. Hallmark of chronic glomerulonephritis is that inflammatory process has been for years and years, and inflammatory cell produce lot of growth factor, and those growth factors activate fibroblasts, and fibroblasts produce lot of, let's suppose this is glomerulus. If inflammatory process here is for very long time, inflammatory cell produce lot of growth factors that produces fibrotic changes there, because fibroblasts lay down lot of collagen and this become collagenized. And if glomerular system become collagenized, will the system work? No. And over the years, if some of these are not treated, they convert into chronic glomerulonephritis. Let me tell you an example. Patient who come with SLA, he initially may come with selective proteinuria, then he convert into non-selective proteinuria, then he may convert into nephrotic, then he may convert into nephritic, or if membranous change in SLE remain for many years, eventually he may become into chronic renal failure, right? In the same way, patient with membranoproliferative disorder may come with nephritic, but if you don't treat it, eventually become chronic end-stage renal failure. Is that really clear? Now, it means out of these all glomerular diseases, we have one basket for acute failure and another basket for chronic failure. If disease is very severe and rapidly progressive, disease will end up into acute renal failure basket. If disease is going slowly but over the years and not treated, this will end up into which basket? Chronic renal failure. Right? That's all about it. But I will revise it with you. Now you have to tell me. I will give you the scenario and you will tell me what's there. Patient comes. Okay, I will start with the biopsy. You are studying a biopsy. Few glomeruli are involved and others are not involved. Some are involved and others are not involved. Epithelial cells are having effacement and few loops of capillaries are sclerosed, hellenized. What is this? Focal segmental. Say it loudly. What is it? Focal segmental glomerulonephritis. Another biopsy you study. Glomerular basement membrane normal. Foot processes of the epithelial cells effaced. No deposits found. Patient is baby and nephrotic syndrome. Glomerulonephritis. Another person comes with hematuria. He has lens dislocation and hearing problem also. Alport syndrome. Another patient comes with severe nephrotic syndrome. You do biopsy and you find that in patient of the nephrotic syndrome, there is a lot of proliferative changes in the glomeruli. And he has been recently suffering with streptococcal infection. Post-streptococcal glomerulonephritis. Another patient is there. He is having hematuria with hemoptysis. IgA nephropathy. He will have linear pattern of immunofluorescence or fluffy pattern or granular pattern. No, I'm asking that if in patient with good posture syndrome, if you do immunofluorescent studies on the glomeruli, immunofluorescence deposition will be linear or granular? Linear, because antibodies throughout the glomerular basement membrane, right? Okay. There is another patient comes to you, and you find that patient is having very thick glomerular basement membrane with nodular deposits and mesangium. Diabetic nephropathy. That's great. That's great. Another patient comes to you, and patient has very thick glomerular basement membrane and epithelial cells have effacement, no other change, but there are subepithelial deposits of IgG and C3. And patient has nephrotic syndrome. What is it? Membranous glomerulonephritis. Another patient comes with acute renal failure. You take the biopsy and you find a lot of crescents in the glomeruli. Crescent glomerulonephritis or rapidly progressive glomerulonephritis. Another patient comes, mesangium has deposits of IgA and immunofluorescence shows fluffy deposits. What is this disease? IgA nephropathy or Berger or Berger disease. Is that right? Is there any question? There's no question? Done? Class dismissed.